at work, and we would run into each other at the proverbial water cooler, or perhaps talking across cubicles or wherever it might be in the office. We would have these informal conversations among colleagues that can really move the needle in some exciting ways. And trying to outsmart the PowerPoint dynamic, we can kind of really quickly zoom out on. Instead, set up this idea of a cafecito meaning small coffee. I am so excited to be here with Dr. Roland Moore and Dr. Emily Houses. We are joining today for a cafecito, which is a short informal conversation among colleagues about the Community Mental Health Equity Project, otherwise referred to as CMEP. The idea of the cafecito is to provide an opportunity for partner agencies on CMEP and key stakeholders in the community to talk about their experiences looking at cultural competence plans at the county level across the state of California, as well as mental health equity work in the community and at the county level. PIRE is one of several partnering organizations on this collaborative project, and Emily and Roland are colleagues from PIRE. PIRE is the Pacific Institute for Research and Evaluation. In a moment, I'm going to invite them to share with us a little bit about PIRE and tell us what they're going to be bringing to the community through the partnership on this project. I would just like to share with the community a deep thanks and appreciation to the ethnic service managers and the county behavioral health directors and the community-based organizations who have been working on mental health equity issues for decades now in the state of California. CMEP is entering this work eager to learn from the wisdom and the learnings that have come along the way since the county cultural competence plans were first established many years ago. And we are very excited to be in community and think together about recommendations to update the county cultural competence plan guidelines that the California Department of Healthcare Services provides to the counties. So with that bit of background, I would also just like to say that this is our intro to the field. We have just started this 2-year project, and we are excited to have an opportunity to hear from our partner agencies. So with that, I want to welcome Emily and Roland and invite you to share with us a little bit about PIRE's work, please.
Thank you, Ileana. Just because I've been around for PIRE about 30 years of its 48 years of existence, Emily and I agreed that I would start things off, and then she will fill in with her extensive knowledge as well. I'm the center director of the Berkeley office of Pacific Institute for Research and Evaluation. It's also known as Prevention Research Center. And we made a name for ourselves in focusing on community-based prevention of alcohol-related trauma. In general, my colleagues and I flip back and forth between looking at the individual level of alcohol, commercial tobacco, and other drug problems, as well as mental health issues, and the wider environment that shapes how we use these substances, how we fare in terms of our health and mental health and well-being. And we particularly enjoy looking at this dynamic between the very big picture and the fine-grained individual experience. So that means looking at things like policy, and that's a perfect connection to CMEP's focus on the cultural competence plans that many of you have worked on for a long time. One of the things that characterizes our work is we're good listeners, and we enjoy hearing what people have to tell us, and then our job is to distill, process, try to make sense of it, and then we bounce it off of people and then refine it some more. And so my training as a cultural anthropologist helped with that. But we also have amazing number crunchers in our crowd, and some of the work that we're doing ties into suicide prevention. For example, my colleague, Dr. Gazelle Garcia Ramirez, and I are working on a secondary data analysis from the military looking at suicide and some of the factors that may serve as early warning signs for service members and their colleagues, the people who are looking out for them. And so this interaction between, again, the big picture, large data sets, policies and nuances, and then how that impacts individual lives is what we do. So before I go on, let me invite my colleague, Dr. Emily Houses, to fill in because I'm sure I've missed a lot.
Thank you, Roland. It's my pleasure to be here today. I really appreciate having this opportunity to brag about our organization. The Pacific Institute for Research and Evaluation is an interesting organization because we have satellite offices around the country. So Roland is there in the Berkeley area. I'm actually calling in from Santa Fe, New Mexico, and I'm affiliated with the office in Albuquerque, the Southwest Center. And so while PIRE itself has a really great research portfolio around alcohol and tobacco-related concerns and health issues, in Albuquerque, our office has a lot of expertise and funded research in LGBTQ youth and homelessness, American Indian elder health, and health policy issues around the American Indian population in general, issues with school nurses and school nursing, HIV prevention and American Indian housing in stable populations. So you could see just as we name these different projects, you start to get this idea of how this group of researchers and research-related support staff have a vast body of knowledge that we come together with. And in this organization, it's really fun because we're from a lot of different sectors. I'm a nurse. I work with a lot of anthropologists, public health experts, et cetera.
It's so exciting to do these cafecitos, to have an opportunity to take a break and just to listen a little bit about what you're excited about and the work that you're doing. I'm finding for myself in 2020, 2021, 2022, that we're just running, even if it's just in front of a Zoom camera. It just feels like there's not the time to kind of take that break among colleagues and have an informal conversation, have a little cup of coffee, a cafecito, or at this stage of the day, I'm having some mineral water. So it's, really nice just to hear a little bit about the breadth of work that you are involved in, and that you have satellite offices and are working across so many different areas. It's really exciting to think about health equity from the variety of perspectives that you're talking about: drug and alcohol use, HIV prevention. It was interesting also to hear about the suicide prevention and veteran populations. We have so many people of color, Black, Indigenous, and other people of color who enter the military, of course, and LGBTQ people who enter the military as well. And those experiences with suicidal crises, of course, are so high in veteran populations, in service member populations, and in our BIPOC communities as well. Which kind of leads me to the second question, which was around the TA. So for folks who might have somehow avoided learning this acronym, TA stands for Training and Technical Assistance. And we invite everyone in the state of California, especially ethnic service managers at the county behavioral health department level, as well as community-based organizations, to submit a request for TA through CMEP to help them in their work in designing county cultural competence plans and implementing the work that is striving for increased health equity in their local community. I wonder if you might talk about particular areas of TA that you feel especially eager to receive requests for? And just as a plug to the field, thank you to the state of California. This is a no-cost TA. So please do go to our website, go to the CMAP website, take 2 minutes to submit a TA request, and know that you will be paired with an expert in the field at no cost to your county or organization. So knowing that, Emily and Roland, what are the kinds of TA requests that you are feeling especially well positioned to welcome?
Well, we appreciate feeling wanted, and it makes us feel good if someone does ask us for TA, and we're quite open-minded and up for just about any adventure. So try us out. How's that for an advertisement? We have some experience based on our service as the Native American technical assistance provider to 7 of the grantees of the California Reducing Disparities Program. These are, for the most part, tribal serving clinics, Native American run and focused and organized clinics up and down the state, small and large, and urban settings as well as rural reservation settings. And their projects are all focused on individual and community well-being, with a particular focus on harnessing traditions and healthy balance to help support people get through any mental health crises they might encounter. Along the way, we've been called on to help with proofreading reports, organizing get-togethers and think tanks. These are highly skilled, highly respected people whom we're serving as TA providers. And similarly, we anticipate that ethnic service managers, CBOs, the county mental health directors also have this wealth of experience and expertise. And so we look forward to engaging with them and learning from them. So we're up for other sorts of expertise as well, if we can be helpful on either the editing side or doing some lit reviews. We're academic types, but we also enjoy engaging with the real world. Although I should have said earlier, although PIRE does have all this academic expertise up its sleeve, what we really value is making our research useful. It's practically oriented. And so however we can serve you, speaking out to the California communities that are looking to update their cultural competence plans at the county level, however we can be useful, let's see if we can help. And let me hand it over to Emily.
Yeah, I wanted to kind of talk about this a little bit more because I'm super excited about it. I'm Native American, and I got into research, which is really kind of taboo in a lot of Native communities, because I saw that there was both a need for there to be Native people doing research so that we didn't have other people talking about us. So there was that. And then I was also really driven by the issues that I saw in the community that weren't being answered. So now I have this gigantic skill set, and I love to respond to the questions that the community is asking. And often that's what TA is they come and they say, hey, we have this problem, can you help us solve it? And so I might have the toolkit that I can pull from to say, these are some of the ways that you can solve that problem. I'm not interested in solving it for you, but I can help you solve it. And that's a lot of what makes me really excited, is being able to kind of put one more brick in that wall that helps them build the house, or can make that connection that helps the system work better. And then, I'm a nurse, so I have some of those clinical skills that are also needed as part of this project, whether it's helping people learn more about trauma-informed care, or all of those little pieces that are really important to mental health care.
Feeling like a bobblehead over here, just nodding away. I am in so much agreement with so much of what you're sharing. I really appreciate, Emily, the humble approach that you just described of listening to the questions that the community has. And I think one of the unspoken, for myself at least, truths of providing TA is that I oftentimes learn a lot myself as the TA provider. When I have an opportunity, as Roland, you were describing, to sit and listen to people, oh my gosh, I receive all of these pearls of wisdom from the local community perspective that you can only gather if you're part of the community. And what a gift it is when people will take the time to share with us the questions that they have. And oftentimes also the strengths and the resiliencies and the insights that they have as well. And I think that is another piece that connects to the trauma-informed approach you were just mentioning, Emily. In 2020, 2021, 2022, unlike, well, I'll just say this. I don't know that any of us have been able to get through these years unscathed by the chronic stressors that are happening, from the pandemic to the wildfires to megastorms, and also to the systemic racism in society. And I just think about the profound work that ethnic service managers are doing at a county level and how hard it is to do health equity work at any time, but especially during this period when compassion fatigue and burnout are really taking a toll on our behavioral health workforce. And so that trauma-informed approach, I hear that as being absolutely essential, not only to the way that we approach TA as a content, but also the way that we engage in that TA relationship. Because so many of us are frankly a little crispy around the edges after 3 years of this business. And many of us have lived entire lives with chronic stressors and chronic racism and other issues around homophobia and transphobia and biphobia. And so I really appreciate that you elevate that trauma-informed perspective. I wonder if you might talk a little bit about additional projects or initiatives that PIRE is working on at any of your satellite locations that you would like to share with the field. It's such an opportunity to hear about your great work.
Well, one that comes to mind is there's a group of economists that are thoughtful, and they pick apart how much does it cost really at the state level or even at the national level for young people to get a hold of alcohol, or for anybody to access guns that are lying around the house. What are all the direct costs? What are all the indirect costs? And when you tally that up, it gets into the millions and the billions. That's the sort of thing where, again, it's kind of academic people, but with an orientation to how can this information be useful? And that information is plugged back into reports that, among other things, inform policy and how money should be allocated by various levels of state or national government. And when you have the numbers in front of you, then it's a heads up about, well, maybe additional restrictions need to be in place to keep these substances out of the hands of young people, or maybe looking at ways people can harm themselves. How can we create better locking systems? Because again, look at the cost. There's a variety of other projects, some of which are in the more quantitative realm, and then others qualitative. And then we have a great array of mixed method studies too that are looking at things like how school health centers have helped young people in a variety of school settings and how those might be improved. Emily, what are some examples that come to your mind?
Sure. Recently here we developed a sexual and gender minority toolkit for primary care providers. It's a website that primary care providers can go to, where they can get more information about how to be better healthcare providers for all of their patients. And I don't know how many hits they've put out, but we have provided the link, and I think that will be associated with this Cafecito. But the link is lgbtqprimarycare.com. Another project that I'm really excited about that I've been involved in is the Native American Elder research project, where this is really community-based participatory research at its best. It was a project that the community brought to PIRE. The principal investigator wrote the grant, she got the funding, and she's been working with the community all along. I came in partway through as somebody to work on it with data analysis. But we have found so much really important and rich information about the barriers to care that Native American elders experience. We've been able to provide some really tangible suggestions on how to address that. We created a website that is full of resources. They're Southwest-based, but there are things that elders can use around the country, particularly suggestions around advanced directives, pretty generic stuff about Medicare. I guess that may not apply in California, but anyway, that website is nativeelderhealthguide.com, and we have so many papers off of this. If you just look for my last name, you would find those papers on PubMed. And so those are some projects that we have either current or recently finished. I think for the sake of time, I mean, I could just talk about my research all day long, but you don't want that.
I really appreciate both of you and sharing. I think this piece around the data, Roland, and the cost, this is so important from a CCP perspective. I understand that it is not uncommon that when counties are completing their cultural competence plan, being able to access data, being able to utilize the data within the cultural competence plan, and then devising a plan during implementation that adjusts and moves with the reality of the community and the things that are going on with these huge variables that are affecting, of course, health equity and mental health equity among historically marginalized communities, I think is really, really key. And that community-based participatory approach that you mentioned, Emily, that is exactly the kind of work that we are so excited to be in partnership with the communities across California on. That is what you were talking about with this following the questions that the community is defining. And I just also appreciate that both of you have talked about diversity issues in a way that goes beyond the traditional race ethnicity discussion. You've talked about age. You've talked about service member and veteran status. You've talked about schools and school health. And we know right now that our K through 12 mental health issues are really at the forefront. And whether we're talking about this issue from the perspective of school mental health providers, or we're talking about it from the perspective of students or teachers or aides or family members as well. These health equity issues are just, there is so much need right now that is being amplified by the challenges that are going on. And of course, we know that our communities of color and LGBTQ folks and people who are living with disabilities are being most impacted, whether it's by COVID infection rates or whether it's by our Latinx communities who live in rural areas, and Indigenous peoples as well who live in rural areas that are most prone to these wildfires right now and other types of issues. So I appreciate you taking a few more moments to share with us about your great work, and especially these really concrete resources that you're creating. We are truly honored to work with you and excited to see where this project goes in partnership. So thank you both for being here today. And to our audience, thank you for checking out this Cafecito. Please do take a moment to click on those links that we will put into the Cafecito as well. Thank you all.
Thank you for having us. And yeah, we look forward to providing whatever TA that people request, we'll do our best. And if we don't have the answers, our immediate team, we have an amazing network of colleagues, and so even if we can't help with something directly, we'll shake our network and see who has the relevant info that might be helpful for our listeners.
And if nothing else, we're really friendly. Thank you.
That's right.
I absolutely co-sign that. And yes, raise a glass to thank you for both of you being here, and look forward to the next opportunity to have a little cup of coffee with you and with others. Thank you so very much.